Good afternoon, everybody. Thank you all, and thanks to Professor Di Somma for this opportunity. Thank you for the presentation. Today I'm going to talk about the utility of new biomarkers point of care for risk stratification of patients with sepsis in emergency department. The aim of the study was to evaluate in sepsis patients in emergency department the prognostic value for bioadrenomedulin and proencaphalin A. Penkid is important for sepsis because it rises faster than creatinine in case of acute kidney injury. BioADM is important because it interacts with endothelial cells and smooth muscle cells, modulating endothelial barrier and contributing to hypotension and organ failure. Today is even more important because we have adracizumab, that is a human engineering antibody that can partially inhibit this effect. From May 2021 to September 2021, we enrolled 85 consecutive patients with suspicion of sepsis in the emergency department of Azienda Ospedaliera San Giovanni Addolorata in Rome. For each patient at emergency department arrival, we evaluated clinical history, physical examination, routine laboratory tests including procalcitonin and C-reactive protein, bioADM and Penkid using a point-of-care instrument called IB10 from Sphingotec, QSOFA and SOFA score, imaging results, diuresis and need for inotropes. Then we performed a phone call follow-up at 30 days to evaluate adverse events. Nexus IB10 is a point-of-care immunoanalyzer that can measure in whole blood multiple biomarkers. By utilizing this device, we were able to obtain the results of our biomarkers within 20 minutes. As I said, we enrolled 85 patients. The median age was 74 years. 49 of them were male. The median SOFA score resulted to be 3.6. The most common ear disposition word was the low-intensity word, but 10.6% of our patients died in the emergency department. The most common septic focus was the lung, and the second one, the urinary tract. 13.1% of our patients needed inotropes to sustain blood pressure, and in all of them, we used norepinephrine. At the end of the follow-up, 25 patients died. At first, we divided our population into groups. The first one with SOFA under 2, and the second one with SOFA over 2. As you can see, there are some statistical significant differences between the two groups. Patients in the second group had a higher percentage of death. Worse parameters at arrival, like a lower DCS, higher respiratory rate, higher body temperature, a lower PF ratio, high levels of lactates and procalcitonin, and a lower arterial oxygen content. Then we check our biomarkers for values of SOFA. And as you can see, we used the cutoff for bioADM of 70 micrograms per deciliter. A positive bioADM was only found in septic patients, so in patients with SOFA over 2. We didn't obtain the same results with Penkid. That was positive in patients with acute kidney injury, even if they had a SOFA under 2. Then we confronted Penkid with a marker of kidney function. As you can see, Penkid was much higher in patients presenting to the emergency department with oliguria or anuria. And we also found that high values of Penkid at arrival matched with high values of creatinine at arrival. Then we analyzed final disposition from emergency department. And as you can see, bioADM was much higher in patients dying in emergency department. And it was even more predictive than SOFA score and Penkid. Then we used Kaplan-Meier analysis to confront values of Penkid with survival at 30 days. And as you can see, we didn't obtain a statistical significant result. Instead, we did obtain a statistical significant result for survival at 30 days with Kaplan-Meier analysis, both for SOFA score and bioADM values with a cutoff of 70 micrograms per deciliter. The most interesting result was obtained considering Kaplan-Meier analysis for the combination of bioADM and SOFA score. Because, as you can see, in patients with SOFA score over 2 and bioADM under 70, we had a higher survival rate than in patients with a positive SOFA and a positive bioADM, with a statistical significant result. In conclusion, in patients with suspicion of sepsis in emergency department, SOFA score confirmed to have a risk stratification value for mortality. BioADM obtained with a point-of-care device showed a significant prognostic value to predict 30 days mortality. BioADM and SOFA score seem to have a similar prognostic value for mortality. And from our data, seems that using SOFA score plus bioADM, it's possible to obtain a stronger predictor value for mortality than SOFA score alone. Sepsis patients with a bioADM over the cutoff of 70 could be the ideal candidate for the use of adrocizumab in emergency department. SOFA score use is also been validated only in ICU, but never in emergency department. It requires blood exams, which are often available after 90 minutes, while in our study, bioADM was available with this point-of-care device within 20 minutes. Penkid, obtained with this point-of-care system, confirmed its role in mirroring real-time renal function. Thank you.
Thank you, Silvia. Very, very interesting. Your relation very interesting because fast time, fast diagnosis, fast and appropriate therapy, new concept in emergency department. Very, very interesting. I think there is time for any question if you have curiosity about this. Have you not? So, Silvia. I want to ask you, in your study, did it find, or it seems so a clear relationship between intensity of care and SOFA score and biomarkers? Can you tell something about this? Thank you.
So, I think it was more interesting watching at death in emergency department because the intensity care recovery often depended by the choice of the physicians. And even if the parameters matters, I think that the decision of the physician was more important in the, choosing in which ward recover the patient. Also, I saw that levels of Penkid was much higher in patients recovered in the medium intensity ward. And I think that is because levels of Penkid matched with kidney failure. And kidney failure is often recovered in medium intensity ward or low intensity ward.
Thank you very much. So, Francesca, I don't know if you have any question or we could go on.
Why did you divide in two groups, SOFA, measure over 2, and or?
Okay, yeah. Thank you for the question. We consider patients with SOFA over 2 septic patients. Patients with SOFA under 2 usually have a better prognosis. And so we divided our population basically in non-septic and septic patients. But as I said, the SOFA score is difficult to apply in emergency department. I think the future is in these biomarkers.
Very difficult, yes, in the real life of emergency department. Okay, I think we can move on with the third presentation. Thank you, Silvia.